Hello everyone, I'm Leandro Chambroni, and in this lecture I'm going to talk about the predictability of root coverage procedures based on the main clinical scenarios that can be found in daily practice and on the potential clinical options supported by the periodontal literature. I'd like to state that there is no conflict of interest related to this presentation, that some images were rotated, cropped, and were resized to fit screen but without altering the baseline characteristics and treatment outcomes of the case presented, and all photos and clinical illustrations presented here belong to the author and his co-workers. That said, I'd like to share with you how root coverage can improve the health, beauty and well-being of our patients. And in order to do this, in this lecture I'm going to briefly comment on the importance of understanding the patient's individual needs. The main root cover procedures reported in the literature and their expected clinical results. Also, we're going to talk about treatment predictability based on the different clinical scenarios developed by the American Academy of Periodontology and their treatment options. The decision tree for soft tissue root coverage, and finish with some concluding remarks. So, let's start talking about the importance of understanding the patient's individual needs. And in order to do this, it's expected that the proposed surgical procedure should not only try to restore as much as possible the lost gingival tissue or to reduce the area of root exposure, but also to identify the potential causative agents related to the onset and progression of the defect. So, we have to find out what benefits are important to our patients. For example, whether the patient is concerned with the deterioration of the dental and gingival aesthetics, or the development of the recession as associated to root abrasion, or buccal cervical dentin hypersensitivity that may lead to dental biofilm accumulation, inflammation and ulceration of the gingival margin, or root caries. After that, we can propose a treatment to our patients in terms of what is important to them. Currently, the successful treatment of gingival recession is based on the use of clinically predictable soft tissue root coverage periodontal plastic surgery procedures. Basically, since the 1950s, 4 primary surgical techniques have been developed. In the 50s, the lateral positioned flap, then in the 60s, the coronal advanced flap, between the 60s and 70s, the free gingival graft, and the middle 80s, the subepithelial connective tissue grafts. And all of these procedures may be associated to different biomaterials, such as membranes, bone substitutes, enamel matrix derivative proteins, allogenic or chenogenic collagen matrix. And it's important to comment that all of these procedures aim to improve the aesthetics and function. Also, to create a shallow gingival sulcus after the surgical procedure, to improve the keratinized tissue band, and also to achieve some root coverage. However, the predictability of root cover procedure may be associated to different patient, procedure, or outcome related factors. For example, regarding patient related factors, we may consider the anatomy of the defect, the periodontal biotype, the local and systemic conditions, and the patient's expectations. Regarding procedure-related factors, we may consider results achieved by the different root cover procedures like flaps or grafts and the clinician's expertise. And in terms of outcome-related factors, we have to consider also the clinical results versus patient-centered or reported outcomes. So, after briefly discussing about the patient's individual needs and the expected results achieved by root coverage, let's consider the treatment predictability based on the different clinical scenarios and potential treatment options. The results of the available systematic reviews on root coverage unanimously indicate that all periodontal plastic surgery procedures are safe and can lead to clinical significant gains in gingival recession depth and in clinical attachment level. Moreover, according to the definitions for the strength and direction of recommendation regarding the need of therapy and procedures defined by the United States Preventive Services Task Force, adapted by the American Dental Association, shows that the evidence quality rating of these procedures is strong. That is, evidence strongly supports these interventions or the treatment of recession type defects. On the other hand, we should consider that not only localized and shallow recessions will be forward to treatment. As clinicians, we may face a diversity of clinical scenarios. So, let's talk about the most common conditions pointed out by the American Academy of Periodontology in its recent regeneration workshop. This review assessed the predictability of root coverage procedures according to the diversity of potential clinical scenarios and treatment options available in the literature. Based on the outcomes of 17 systematic reviews, 94 randomized clinical trials, and 11 sets of meta-analyses that evaluated Miller Class 1 and 2 defects, and 121 papers that evaluated Miller Class 3 and other conditions. So, it's important to highlight that according to the most widely used classification of marginal tissue recession described by Miller 30 years ago, complete root coverage can be anticipated for both class 1 and 2 defects, and this is because there is no periodontal tissue loss in the interdental area. While the same could not be expected for class 3 and 4 recessions, where bone or soft tissue loss in the interdental area is present. But let's move forward to the AAP clinical scenarios and answer some specific important questions commonly made by clinicians in their daily practice. Clinical scenario 1. Best treatment options for the treatment of class 1 and 2 recessions. And the questions are the results of therapy stable? And what is known about the attachment of the graft or the flap to the root, and is it important? And is it possible to estimate the outcomes and propose treatment options? That is, establish a decision tree. We're going to talk specifically the decision tree in the end of this presentation. And is it possible to obtain satisfactory results when treatment patients who smoke? Regarding the laterally positioned flap, this is indicated for the treatment of recessions adjacent to the donor teeth presenting a width of attached keratinized tissue of at least 2 millimeters and thick periodontal biotype. But the literature says that most of the research available for this procedure relies on non-randomized studies performed at the 70s and the early 80s. So, according to the evidence quality rating developed by the American Dental Association, the evidence is weak. That is, the evidence suggests implementing this intervention after alternatives have been considered. With respect to the coronally advanced flap, this is indicated for the treatment of class 1 defects presenting a band of attached keratinized tissue, also at least 2 millimeters, and a thick periodontal biotype for both single or multiple recessions. For this approach, there is a clear evidence that coronal advanced flap alone leads to significant clinical gains in gingival recession and attachment level as well. However, such procedure does not promote improvements in the width of a keratinized tissue, and the evidence quality is in favor. That is, evidence favors providing this intervention. Regarding the graft procedures, for instance, the free gingival graft, this can be used to treat narrow recessions. That is, recessions with less than 3 millimeters of width located in areas without aesthetical demands, like this mandibular recession. But the evidence suggests that free gingival grafts may lead to significant clinical gains in gingival recession, in an attachment level, and in the width of keratinized tissue. On the other hand, the strength of recommendation is weak. Evidence suggests implementing this intervention after alternatives have been considered. Regarding the use of subepithelial connective tissue grafts, these may be used for the treatment of upper or lower recessions located in the anterior or posterior sections. Here we have an example of the use of the subepithelial connective tissue graft in association to the coronal advanced flap without releasing incisions, where we may see very good outcomes in terms of aesthetics and improvements in the keratinized tissue band at the 6-month and 1-year follow-up. The base of evidence suggests that the subepithelial connective tissue graft-based procedures lead to the best outcomes for clinical practice when compared to most other surgical techniques. And in general terms, the subepithelial connective tissue graft is up to now the best procedure available for clinical practice. That is, it may be considered the gold standard procedure. In terms of wound healing of root cover procedures, the available information on human histology showed that wound healing may be anticipated consisting of long junctional epithelium and connective tissue attachment. But it should be noted that it's not easy to access data from humans due to inherent ethical conditions. But previous study samples like this one from the 80s may be reanalyzed to obtain outcomes that were not accessed at the time, regarding, for instance, the dimensions of the epithelium, where we can note that the clavicular epithelium is somewhat similar to non-treated areas, as well as the junctional epithelium is longer than untreated sites. Also, we may note that there is some connective tissue attachment with fibers parallel to the root and some PDL inserted in the newly formed cementum in the bottom of the defect. With respect to the impact of smoking, smokers may be benefited by root coverage as well. But differently of this old merchandise material, I would not recommend my patients to smoke. Smoking clearly leads to a detrimental impact on surgical therapy. It may be expected that smokers may be benefited by root coverage, but amount of root coverage and the number of sites achieving complete root coverage will be decreased, especially within subjects treated with subepithelial connective tissue grafts. Also, smokers may present greater recession recurrence. On the other hand, at this point in time, the effect of treatment of smoking and non-smoking patients with flap procedures seems the same. However, we should account that there is limited information available for a definitive analysis. But as said in the previous slide, and demonstrated in this case, smokers may be benefited as well. So let's move forward to the second clinical scenario. And this clinical scenario regards the treatment of Miller class 3 and 4 recessions. So can the odds of achieving a satisfactory result be improved for such defects? And is it possible to use a flap procedure alone, or should a graft or biomaterial be used with it? And will a restorative or prosthetic approach be required to complete the treatment? And the literature indicates that the marginal level of the gingival tissue of teeth adjacent to the gingival recession seems to be the clinical reference point when planning and foreseeing the expected results of class 3 gingival recessions, as we can see in this case. But it should be clear in mind that root coverage is still unpredictable for defects like this. However, upon the patient's request, we may use combined peri-restorative therapies in an attempt to improve aesthetics. For example, the use of a subepithelial connective tissue pedicle graft in association to a currently advanced flap and composite restorations after wound healing. Besides, we may note gingival tissue firmly attached to the root surface, and shallow sulcular depth were evident upon probing, while the proposed therapy yielded satisfactory clinical results. The next clinical scenario involves other defect risk factors for root coverage. For example, are the geometry and the degree of recession important? And is the amount of keratinized tissue gingiva important to decision-making process? And does the degree of keratinized gingiva and the final outcome affect the long-term stability of cases? We should account that the osteoid morphology of the treated sites is dependent of the structures attached to the tooth, as well as to the structures and position of a tooth. Anatomical features of the alveolar bone, such as bone fenestrations and dehiscences, may be important for the development of gingival recession and for the prognosis of treatment. Another important anatomic condition that may modify the soft tissue behavior around the tooth over time is the periodontal biotype. And this is because thick and thin biotypes present different histologic characteristics in terms of osseous architecture, CJ location, quality of gingival fibers, and keratinized tissue. Teeth with a thin periodontal biotype seems associated to an increased susceptibility to gingival recession when compared to teeth with a thick periodontal biotype. Regarding to the keratinized tissue, patients treated with graft procedures and their consequent biotype improvement benefited by more stable outcomes and less recession recurrence. These outcomes are probably associated to sealing and mechanical characteristics provided by the restoration of keratinized attached gingiva over the previously denuded root surface. So we should carefully assess the characteristics of the defects and the adjacent teeth in order to provide the most suitable procedures for the patient. For instance, in this case, there is a clear need for improving the periodontal biotype of the area, not only to cover that single recession, but to prevent the development of further defects as well. On the other hand, within patients presenting deep wide recession defects and the thin periodontal biotypes, different surgical procedures may be used not only to improve the keratinized tissue, but to cover as much as possible those exposed root surfaces, like in this case where we have 2 class 3 gingival recessions in an area of a thin periodontal biotype. In terms of the location of the recessions, it doesn't matter if we're treating a maxillary or a mandibular recession or an anterior or a posterior defect. All of these defects may be equally benefited by root coverage. However, keratinized tissue gain can be superior in the maxilla, but we should account that it is irrelevant, that such outcome is irrelevant in clinical terms. Moreover, long-term stability is associated to biotype modification or a keratinized tissue increase of the area. The next clinical scenario number 4, regards the treatment of non-carious cervical lesions root surfaces. And the questions are, should the presence of a non-carious cervical lesion alter the treatment approach, and do these areas need to be restored? And if yes, before, during, or after the surgical procedure? And the literature indicates that these lesions may be safely treated by subepithelial connective tissue grafts in association to the coronal advanced flap or calf alone. But there is no significant differences between lesions restored or not. And there is no evidence on the optimal timing for restoring these lesions, that is, before, during the recovery procedure, or after wound healing. In terms of the histological healing of these defects, here I'm showing you some unpublished material. We may note that there is the formation of a long junctional epithelium over the restored area. So we may opt to restore or not these defects. Here we have two examples showing the use of subepithelial connective tissue grafts in association to the coronal advanced flap, but no restoration of the sites. In this other slide we have both restored and non-restored areas, both of them treated with subepithelial connective tissue grafts. And this last case, published in the Clinical Advances in Periodontics, make it clear that the future gingival margin will probably rely on the CJ area, or in the original CJ area. The next two clinical scenarios will be presented together because they are restricted linked. Clinical scenario 5, the treatment of gingival recessions, not surgically treated but restorative composites. And the questions are, what is the best technique material to graft over these previously restored root surfaces? And should the restoration be removed or changed? And is it safe and predictable to surgically treat these areas? And clinical scenario number 6, the treatment of carious root surfaces. Is it possible to cover carious root surfaces? And after removing the caries, it is obvious that restoration will be necessary, and how does that change the treatment plan? And similarly to braided surfaces, do these areas need to be restored before, during, or after the surgical procedures? Well, literature indicates that these areas may be successfully treated, but the carious dentin or the root restoration need to be removed. And those root surfaces should be meticulously planned prior surgery, but unfortunately there is no solid evidence from randomized clinical trials. Most of the evidence available comes from case reports. In these examples we may see that after removing the old restoration or the carious tissue, very good aesthetical and functional results may be achieved with therapy. The next two clinical scenarios will be also presented together. Clinical scenario number 7, a complex case involving multiple recession type defects in aesthetic areas. And the questions are, is there sufficient donor tissue to be removed from the palatal vault, and is it safe to use a flap procedure alone, or should other biomaterial be used, and what factors will lead to the best choice? And clinical scenario number 8, lack of adequate donor site. What are the risks and benefits associated with the use of allogenic or xenogenic graft substitutes, and do they provide evidence of long-term stability? Usually, subepithelial connective tissue graft harvesting occurred in an area comprehended between the distal aspect of the first premolar and the medial aspect of the second molar. However, the amount of connective tissue that can be harvested from the palatal vault will be dependent on the anatomical characteristics of that area. For those cases where we have enough connective tissue to be harvested from the palatal vault, even for areas like this one, comprehending 3 gingival recessions, we may achieve very good statistical and functional results. On the other hand, for those cases where there is a lack of adequate donor tissue because of the anatomy of the palatal vault or the extension of the recipient bed and the number of recessions that need to be treated, the use of flaps alone or associated to other biomaterials may be used as well. But the literature indicates that both allogenic dermal matrix graft and enamel matrix derivative can provide the best outcomes of treatment. So, for those cases where a subepithelial connective tissue graft cannot be used, we should provide options to our patients. For example, in this case where we have multiple recessions treated with the coronal advanced flap, or the use of allogenic dermal matrix grafts, even in sites of single recessions, but for those patients that do not want to be harvested from the palate, or even chenogenic matrix grafts. This is a new material compared to the allogenic dermal matrix graft. It's an enamel matrix derivative, but it can also lead to very good aesthetical and functional results at the short term. So, the base of systematic reviews indicates that both enamel matrix derivatives and acellular dermal matrix grafts can improve recession depth, clinical attachment level, and the keratinized tissue band. Also, the chenogenic collagen matrix may be used, but the amount of information of this material is still limited. Clinical scenario number 9, the last one, regards patient-reported outcomes, where most patients are interested not only in recovery but in achieving the best color and texture match. And the unique question for this clinical scenario is, what technique should be used to achieve these goals? And I will answer this question just showing this slide. We may note that the best color match and aesthetics will be associated first with the site you're treating, second with the aesthetical demands of your patient, and third with the quality of the periodontal biotype adjacent to the recession sites. So, based on these different clinical scenarios and treatment options, we can provide a decision tree for the soft tissue root coverage. And the decision tree for soft tissue root coverage proposed by the American Academy of Periodontology indicates that wound healing consists of a long junction epithelium and connective tissue attachment. And that decision tree seems better designed for determining appropriate treatment of single sites, but it may guide the treatment of multiple recession type defects, and that the use of root modification agents does not alter the clinical outcomes. In terms of the type of the defect, for class 1 and 2 recessions, for most of the available conditions, the subepithelial connective tissue graft can be considered the gold standard, except for those cases where there is an impossibility of harvesting the patient's palatal vault. And for class 3 and 4 recessions, the subepithelial connective tissue graft should be also the first choice. And remembering that the amount of root coverage will be based on the amount of interdental soft tissues lost. So, after considering